So I think we became really interested in what is the impact of low trust during COVID in particular. I mean, it was there before COVID, of course, but COVID shone this spotlight on health inequalities, and suddenly people were interested in why there was a huge difference in uptake in vaccination between the most and the least affluent groups. It's always been that way for every vaccination, just about. But for the COVID vaccination, there was more, I guess, political public urgency around making sure that everybody had access to vaccination. And I think there was this kind of fresh interest in what is it that makes people feel unable to vaccinated, and a lot of it came down to trust or bad experiences of healthcare, or feeling healthcare wasn't for them, or there was all sorts of reasons, which meant that even if the information was presented in a way that folk thought, yeah, that makes sense for some folk, but it's not for me, I don't trust it, that I think we just had to be humble in that and recognise that our sometimes quite authoritarian healthcare systems don't work, and they create divides. So I think a lot of it was about trying to understand what has driven low levels of trust. And I think almost kind of I've become really, really interested in the last few years about the role of relational continuity of care. Not a new thing at all, quite an old thing. In many ways, a lot of people feel it's quite an old-fashioned thing, but we've kind of lost it. And we're beginning to see the impacts of losing relational continuity of care within general practice, because we've become so much more focused on speed of access and just being seen quickly by anyone, rather than being seen within an appropriate timescale by someone you know. And if you see someone you know, you're more likely to be able to have those conversations, which at least can then unpack it a bit. And we know that if someone has got a relationship of continuity, they feel more able to take up advice because they trust the person that's giving them the advice. And none of that feels very high tech or rocket sciencey, but it just, so for me, it's about, so how do we create the conditions to make that feel more possible?
Not to dwell too much on the kind of COVID and lockdown and all that, but some of that is kind of instructive in the link between public trust, where that trust is cultivated, how it's cultivated, and the latitude that then grants decision makers to deal with a crisis. So during COVID, we had a lot of debate about, well, look what Denmark's doing, look what Sweden's doing, look what Norway's doing, or other countries, and saying, why can't we do that here? And there are many complicated reasons for that. We could have tried it. We could have just said, right, you guys just decide for yourselves what to do, and we'll let this run through. But actually, the key ingredient, I would argue, was public trust and governance, which is not a feature of UK culture currently. And part of that, there are historic reasons for that, but these countries are fundamentally managed differently. So people in those countries see the benefit of, contributing through taxation to the system. They feel that it's tangible. Their criminal justice system operates different from ours. Their healthcare systems operate different from ours. And so that public trust is really key, isn't it? And I guess whether you like it or not, you become a kind of avatar for public services and every interaction that you have. But that's an immense toll, isn't it? So I thought maybe you could talk a lot about your personal investment in this and the cost to you for going over and above maybe what some of your colleagues might do.
So I think, it feels to me that trust is one of the hardest won things. And when you feel that trust has been established, you should never do anything to jeopardize it, because it can take 10 years to get a relationship of trust with somebody. But I think that I'm also aware that a lot of the work that we do, particularly in the deep end as clinicians, given the backdrop of low levels of workforce, high levels of workload, lots and lots of unmet need, that it can feel like quite a stressed and hot system. And I think in an ideal world, what I would love to see is all the clinicians working in that system feeling supported and enabled to be able to have relational continuity and develop trust over long periods of time. But that work is hard. It's emotional labour, which we don't really often talk about very much, or recognise very much. We don't recognise why am I exhausted at the end of the day? It's not just because it's been a long day, it's because I've invested a lot of emotional labour in that. And my friend and colleague Adam Burley, who's a clinical psychologist, he's got a really good analogy that he uses around the safety nets that are in place when you're in a physical labour job, as opposed to the lack of safety nets when you're in an emotional labour job. So he talks about, if you were going onto a building site, you would have to wear your hard hat and your digger boots, and you'd have to wear high-vis stuff, and you'd have to do your health and safety training, and you just wouldn't be allowed in otherwise. But if you go into an emotional labour job like healthcare, particularly when you're working with people with a history of psychological trauma or adversity, there's none of that. There's no safe space to reflect on how that can feel in a consultation, and why sometimes it might feel quite difficult. There's no requirement to do trauma-informed training. And I think people kind of can put themselves in harm's way without really recognising what's going on. And what I worry is, without a recognition of that, and without the safety nets in place, what tends to happen then is that clinicians can start to develop coping strategies that are not good for patients. Like they might say, this patient has DNA'd, they've not turned up twice, we're going to put them off the list, we're going to see them in twos, we're going to get a behavioural contract in place, we're going to work less hours because it's difficult. And that might be quite a subconscious thing that's going on, but it's all about withdrawing yourself. Because being in relationship with someone over a long period of time is hard work. So I think it would be great to just have more recognition of the emotional labour of any role that involves giving care, not just health, but criminal justice, education, lots of roles where you are in relation with people.
Let's kind of double back and unpack this continuity of care thing. Because I mean, it's sort of implied what it is, but it's now in the current context where you don't know who you're going to see when you phone, and you've got to kind of get round the receptionist, or the feeling that you've got to get round the receptionist, that continuity of care is lost. And that's not just about having familiarity with a doctor and sort of like, oh, how you doing, doctor, and picking up the chat. This is about a doctor building up a more intimate understanding of the picture of someone's life, because the more a doctor understands about all of those factors, the more accurately and precisely that they can get to the root of an issue, whatever that issue might be. And from the patient perspective, it's about letting your guard down. It's about being able to talk in a kind of shorthand with someone because they understand things that don't need to be explained. Today, so many health encounters, or public service encounters generally, particularly around welfare, social security, the immense labour involved for the person who is seeking help is that they have to retell and restate basic facts about themselves, about their circumstances. They have to clarify certain bureaucratic obstacles that they have overcome or not overcome. And this in itself is a massive disincentive to even go for the help that you're legally entitled to. So continuity of care in an ideal situation. Can you describe how you try to meet that need, the importance of that need, and also you made reference to link workers. That's a kind of continuity of care, isn't it? That's a face that people can see. They know that that's representative. So maybe just unpack some of that. I know that's another big.
No. I mean, I remember you talking at one of the Deep End events really powerfully about the impact that that it had on you, having someone that you felt you could have this, I think, shorthand or shortcut to kind of intimacy, or just being able to get there quickly without having to retell your story. And I think in many ways that's it. In a time constrained environment, the time is so precious that not having to retell your story automatically gets you to where you need to be. But it's amazing when you start to look at what the evidence base, what the science tells us. If you've got continuity of care between, and it's most of the published stuff is about GP and patient. If you've got continuity of care over a period of time, care is safer, it's higher quality, you make better decisions, people have better experiences of the healthcare system. They're likely to live longer. They're likely to be less sick over their life. They're likely to use A&E and out of hours less. They're more likely to take up advice if it's given, more likely to take up screening and prevention stuff if it's given. And it reduces health inequalities as well, because of the really essential stuff that happens around trust and people feeling safe to be able to disclose stuff that's happening for them that might otherwise just feel really difficult or sensitive or shameful to talk about. So when you see the evidence base laid out, you think, if that was a drug, we would be putting it in the water.
Yeah.
So why aren't we?
Yeah.
You know?
Yeah.
And so then I became interested in who are the people that really benefit from it, because in an ideal world, everyone would have it. But we don't live in an ideal world, and we probably need to make sure that the people who really need it have it first, while we work out how we get back to a place we need to be. So people who are older, frailer, have lots of long-term conditions or complex health issues, people who are having palliative care and that are at the end of life, people with significant mental health issues, people with addictions problems, people living in poverty, have all been shown through the science to benefit more from having someone that they know, like a named person that they see as much as possible over time. And some of the things that have made that difficult in the last 10 to 20 years are that we've largely been much more interested in how quickly people can be seen rather than who they are seen by. So I think being seen quickly is really appropriate if you're sick, obviously.
Yeah.
But actually maybe waiting a little bit of time to see someone you know is also important. So kind of thinking about access is the word that's often used as a wider thing than just about time and more about relationship. Can I have access to a relationship with somebody that I know? And that means things like, are our appointment systems allowing that? So can you pre-book an appointment? Can you phone at any other time other than 8 o'clock? Have you got something in your notes that says this is the person that I normally see? So there are some things that can happen within the system that can make it better, and there are some ways of measuring it that can make it better. It's currently a little bit difficult to do that in Scotland, but I've been told it's going to improve. But there's also probably some shifts that need to happen as well publicly to kind of help people understand that continuity is powerful and important, and that having an Amazon Prime health service isn't always the best thing. That convenience doesn't trump continuity every time. Continuity can be really powerful for all of those other reasons. So I think there are lots of things that we need to do to bring it back. We need to train people as they're coming through training that this is what the evidence shows, this is why it's important, and celebrate it when it does happen. We need to be able to measure it. We need to be able to grow our workforces so there's enough of them. And then we need to have continuity within teams as well, so that we're sharing information in a sensitive way and we're all joined up in the way that we think, and people don't experience healthcare as just being totally fragmented. Which I think is often how folk feel. They feel they're passed around, and how come you don't know this? You're in the same practice, is it not written in the notes? So there's something also about information continuity in addition to the relationship continuity as well.
Yeah, and when we look at the long-standing health inequalities, what we see is that the more affluent communities are experiencing a lot of the things that the poorer communities are being deprived of. So there's greater continuity of care, the kind of the inverse care law model, where where care is most needed, it's least found, and where it's least needed, it's in abundance. And that principle can be applied to education, policing. There's an inversion and it's disproportionate across the whole spectrum. So you can see where inequalities become cleaved and entrenched and formalised systemically. But when we talk about health inequality or any kind of inequality, we often focus on what the poor need to do better, or what the services or the doctors working in the poorer areas need to do better. And there's lack of a parallel analysis of some of the benefits of being born in the right postcode, or being born into a dual income household, or living next to a high performing school. And that's not to take away from the hard work and merit of people who manage to kind of climb their way up. But often people end up in those positions by lottery of birth, which is similar to how some of us end up in poorer communities. So how do we create a conversation where we recognise that talking about what's going wrong in poorer communities is only half of what needs to be discussed, and that there's a real problem that decision makers have to confront, which is about reallocating resources in a way that might upset or trigger people who've come to conflate their favourable circumstances in life with their own merit, when actually the system is kind of rigged for certain groups. And I know that's a kind of small p political question, but you know yourself that there is a kind of, what I'm saying does ring true. And that's a difficult one for decision makers to tackle, and that's partly why the status quo remains such.
So I agree, and I think it is difficult, and it's probably why it's not happened yet. I think sometimes it can be easier to have conversations about it depending on the language that's used. So I think there was a really interesting paper that the Health Foundation wrote, I think I've mentioned them at the start, about framing the social determinants of health and using the language of fairness instead of the language of inequality or disparity. No one's going to argue against a fairness argument. So that was a really powerful learning point for me. So I tend to talk about fair distribution according to where the needs are. And that's really difficult to argue against. I think sometimes as well, there different arguments will persuade different people, won't they? So some people will be persuaded by the moral argument that if you have higher levels of need, you should have more care because healthcare should be at its best when it's needed the most. That was the founding principle of the NHS. But some people will be persuaded by the economic argument. So the economic argument would be if you offer healthcare to the people with the highest needs earlier on in their disease journey and have more prevention activity going on and help people feel able to stay more well during their life and more held within systems. It's extremely expensive to not do it that way because people then feel unheld by multiple parts of public services and ricochet around systems. It's the same often vulnerable families that show up in education, show up in health, show up in criminal justice. So if we have a way of being able to have a much more upstream approach, it's much, much more cost effective for the taxpayer. So that feels also like an argument that's difficult to disagree with, that I wonder whether we need more health economists in and about the conversation as well.
Yeah, excellent. I think there's always room for more economists of any sort. They've not caused any problems. What do you want to do? Do you want to open it up for questions, or have you got anything that you want to ask or say before we?
Can I ask a question? So Carey and I have had a conversation about people who are missing. So I've been looking at people who fail to appear for court. And what we've realised is they're moving house all the time, they, getting a letter from the courts, the most pressing thing that they have. And they're missing, but what happens to them is they get brought into the system, they often get remanded. And you talked about missingness, which I just love as a concept, missingness within health. Could you just tell people a bit what it'll spark a whole range of thoughts for people?
I mean, it's work that's been done within the University of Glasgow by an amazing research team. So I've been learning about it as well over the last year and a half. And it's basically missingness as a concept describes the tendency for people not to be able to take up offers of healthcare such that it results in harm for them. So it's often maybe 2 or 3 missed appointments over the course of a year, either within general practice or in the hospital setting, that then means that people have much poorer health outcomes or in fact are at risk of much earlier death if they have a mental health diagnosis as well. But the missingness word is really important to me because often in healthcare we'll talk about DNAs, do not attend. There's probably a similar acronym in criminal justice, I imagine. And it's a really dehumanizing word, and it makes the clinicians working in the system feel frustrated and a bit judgmental and a bit angry about the waste. I can't believe this person has DNA 2 or 3 times. So the missingness work, I think the kind of light bulb moment for me was changing the way that people feel about people who are missing, from moving away from feeling that folk are irresponsible or lazy or feckless or not able to kind of get their act together to come in for an appointment, thinking, might these be the people who are most in need, who for whatever reason the system is not working for them. It's not their fault that the system is not working for them. It's the system's fault that they are not able to make use of it. And so it turns the whole thing on its head. And what the work from Glasgow has shown is that there are complex practical reasons and psychological reasons why people might be missing from healthcare. And some of the practical ones you would imagine would be things like insecure postal addresses if you rely on appointments going out in the post, or lack of access to transport, or getting time off work if you're in insecure employment. Some of the psychological reasons in many ways are even more powerful. A belief that healthcare is not for me, it's not designed for me, it's not designed with me in mind, or I've had really negative experiences in the past and I don't trust it, or I feel too anxious to go. And all of those reasons that stop people feeling able to make the appointment. So their work has been really powerful, I think, in helping clinicians to understand it differently, and also helping policymakers to design policy differently, to think about, if we were to apply this approach to how we think about people not being able to turn up to appointments and turn the whole thing on its head and measure that as success, then that is really powerful, because that starts to get in and about how we address health inequalities in a really practical way.
Yeah, and I mean, it has big resonance for me in justice. I mean, it's quite interesting that your GP and your hairdresser and your dentist send you out text messages.
Yeah.
We don't text you to tell you when you're turning up for court. And I've not really met that many people who have a filofax with all their all their appointments written down. And so we make it really difficult for people to engage when they're already quite fearful. They're perhaps scared that they're going to get a sentence. And so therefore they become missing. And I think the Venn diagram between the people you're talking about and the people who we serve, I think that's probably huge. But I just wonder, should we open it up for some questions? Have we got any questions coming in?
We've got a few questions. Our first question is from Shamila, and it's a question for you, Carey. What role do you think trauma-informed approaches / practice play in supporting primary health within this area? Are you committed to, for example, all GPs practice getting TIP training? And you might want to explain what TIP training is.
So trauma-informed practice training, I think that getting the training is one part of the jigsaw. I think when we've done some pilot work with practices in Glasgow, where they had a little bit of additional resource. This was from Scottish Government funding, and one of the things they were able to do was to have some additional education or training for their teams. A lot of them chose to do trauma training, and what was powerful about that was that people were helped to understand why some things often felt difficult, and why some people's behaviour maybe felt difficult, or why some consultations felt very anxiety provoking, or why but they would also start to think about, what is it that we can do within our practices to be more trauma informed? Like, can we make it easier for people to register with us, for example? Or can we make it easier for people to stay in relationship with us, so that we don't have a system where if you don't turn up twice, you get put off the list? Or can we have an appointment system that encourages continuity of care? So I think that a lot of that was really useful learning. But for me, the other side of the coin that we often don't think about and talk about is, how do we put the supports in place to allow people to work in that way? So doing the training is great, but often what people would say was, I've done the training and now I understand more what trauma is and what the causes of trauma are and how it can present in people's health and in people's behaviour, and I want to do differently. This is how I want to work. How can you help me do that? And often it requires more time, it requires more psychological support, it requires maybe reflective practice or something that just helps people with the emotional labour of the job, and we're not good at doing that. So I think that the training is great, and yes, I would say I'm committed to it, but I am committed to it as part of a wider conversation about how we have trauma-enabled care, not just trauma-informed care, would be what I would think about that.
Karyn and Dan, do you have anything to add?
No, I'm good. If you want to take another question, we'll get through them.
So we've got a question from Neil, who says, you mentioned our health system being outdated. What are your thoughts, and this is to the group, what are your thoughts on lack of knowledge on sharing protocols between services and having systems that don't talk to each other, impacting on identifying appropriate support or ability to follow support plans, leading to patient and clinician frustration, poor experience and loss of confidence? So what are your thoughts on the lack of knowledge on the sharing between services and systems that are not talking to each other?
Do you want me to comment
That's
briefly?
a huge question.
It is a huge question, and a lot of it is the fact that we don't have the infrastructure to help us do our jobs well. Yeah. So we don't have IT systems that talk to each other across health and social care, even between general practice and hospital care. That doesn't exist either easily, or between other public sector. There is no joined up IT infrastructure. So it makes it very difficult for people to communicate effectively across interfaces of care. And when you try to do things differently, so there was a really great project called the Governship Project, which was funded in Govan for I think 2 or 3 years, where again a little bit of extra pilot funding went in, which allowed people from healthcare, social care, education, often policing, often welfare, criminal justice, to come together to talk about the vulnerable families that they were all seeing in different parts of their service, and to have conversations around how can we plan care more so that we can help people feel more supported and kind of manage things in an upstream way. How can we write care plans? How can we gather information from all our different IT systems? People would be logged into all the different IT systems that they used as part of these conversations, and it worked really well. It's not rocket science, but the funding wasn't continued, and we haven't since had the IT improvements that allow proper, robust, confidential information sharing across different systems, which makes it, I think, quite difficult for services to be joined up, because they're all busy, they're all siloed, and they're all, working under pressure, but essentially often seeing the same people.
Mm.
And yet we seem to be in this age where we are huge leaps in technology with AI, and we were talking about AI just before we started. I have to be glass half full here, that I see a potential for great change to happen. Even though we've got these archaic systems and health seems bad, justice seems terrible. We have it's a sort of series of clumsy handoffs from one organisation to the next. We've got lots of people who are just exiting prison this morning after the early release, who will be going and telling their story to different people every single time, whether it's benefits, whether it's trying to get me a GP. And you just think in 2025 it shouldn't really quite be like that.
Yeah, and just on a kind of broader point, because you guys are obviously getting right into the specifics due to your kind of proximity to it, but if you just look at the difference between how a Starbucks is designed and a public library is designed, it's no surprise that most people will go and read in a Starbucks. And the point about that is that the Starbucks is designed with the comfort and the convenience of the person who walks in the door. You've got natural light coming in, you've got the air, the temperature, everything is just optimised for the comfort of someone who goes in there. And I'm not saying every public library should be like that or can be like that, but it shows that the public services in a state of consistent managed decline for the best part of 4 decades now, with little bursts of investment here and there, then they just fall behind. They just fall behind. And for anyone who's concerned about moving to a more insurance-based model or some other form of private healthcare, the best guardrail against that is to invest in what we've got now so that it's more appealing. Because sadly, despite the fact of the NHS being part of our national character and one of the few things that most of us agree should exist, that is not a permanent position. People will eventually be graduated along a pathway where they will accept a system that they have in the Netherlands or they have in France. They will accept it because they think, well, I mean, it can't get any worse than this. And I think that's wrong. But it really does go down to what is the quality of the experience. And if the computers aren't even talking to each other and we're penalising people, we know that individuals who are in vulnerable situations are partly in those situations because they lack basic capacities and competencies. And then what we do is we say, to get out of your bad situation, which we've already penalised you for, you suddenly need to demonstrate these competencies that we know you don't have. Otherwise, we're going to penalise you again. So you better organise your full schedule. You better organise your arrangements. You better get there, talk to the housing, talk to the benefits, talk to this, talk to that, talk to the next thing. It's completely disconnected. It's completely disconnected from the reality of the situation. But I mean, you already know that.
Next question is from Catherine, who asks, how do we effect the change needed to improve the systems to align with what the evidence shows would address the issues discussed? Quite a big question.
What was the question again?
How do we affect the change needed to improve the systems to align with what the evidence shows would address the issues you were discussing earlier on?
Oh, that is a good question. I mean, and some of this is political, and
Yeah.
obviously we can't speak about that. Darren can probably speak a bit more about that. But, some of it, we've known about the evidence about what works in criminal justice for decades. I spent my time shouting at the radio this morning as and it's great that we've got, people talking about sentencing reviews, about evidence we've known for decades. The trick is to actually put it into practice. And that requires long-term planning, it requires money, it requires staying the distance, even when it gets really tricky. That's the bit. It's the verb that we're missing, isn't it? The doing word. I think we've got loads of the evidence of what works. You talked about relational practice, the identification of the cause of the cause of the cause when people come through your door. But it's we're missing some of the verbs, are we not?
Yeah, and to touch on politics in a small p sense, that's one of the most significant currents in the mix. You could have politicians with all the will in the world, even ones who have a lot of understanding of the issues that they face, and just part of the kind of downside of the democratic way of doing things is that within an electoral cycle, a decision maker has to, first of all, inherit circumstances, local, national, global. They have to get their head around how all the different parts of the civic society and government are speaking to each other, what the limitations are. And by the time they've got their head around that, a new person gets voted in. And that's just the nature of politics. But it's worse in the UK now because of years of poorly managed economy, which means that our decision makers are always managing a crisis. There is never the space to say, let's articulate a vision of a future, like the NHS welfare state moment, where that was very clear, Beveridge report, society of the future, all that stuff. And yet we look at it with rose-tinted glasses now, but we really could do with a moment like that. We could do with a moment like that. And unfortunately, leaders don't feel empowered or confident enough. The UK as a country in the global picture is not confident enough to assert itself in any way. It doesn't know what it wants to be. It doesn't know where it fits. And that all filters through. We can, and that may not seem relevant to the question, but it absolutely is. Because increasingly, despite my kind of background as a campaigner on the more radical side of the spectrum, whenever I talk to people in public services, I have to always try and encourage them not to beat themselves up because they're not out there with pitchforks advocating for a revolution, because they're doing a really good job holding the system together until it becomes clear what comes next. And people don't drive that. People power doesn't drive that. The welfare state wasn't created, the New Deal wasn't created as a result of people power. That was politicians saving capitalism, right? So they thought, we're going to need to give people a better deal or they're not going to buy into this society. A lot of the things that dictate the real direction and change of our society, they don't come from campaigners, they don't come from people. It's bigger currents, bigger than any of us. And so actually just buckling down in your public service or whatever it is you're doing and doing the best that you can, that's a completely legitimate use of your time and energy. Like, you're doing enough. You know what I mean? Like, it's okay.
And that's a great point. Because I see people right now, and I speak to young GPs, and and they tell me how tired they are, and just and they've got reams of people coming through the door, and they've all got these terrible backgrounds and terrible stories, and they have to give that emotional labour. And it's the same in community justice and criminal justice, where people are doing their very best. And I think we should never forget that, that there's some people who are absolutely bringing their whole self to work, and it is a tough gig.
Yeah, it is, and often because of the sort of narratives that are perpetuated about how we can change the world and anyone can make an impact. That is absolutely true, but often the impact that we actually make and the impacts that we can sustain and the sort of change that we can observe, it happens in a way that's quite different from those idealized stories. And sometimes we can miss it because we're too busy looking at the structures and the leaders and the narrative and the politics of things. And I know this from my work in mutual aid recovery groups. I've been rabbiting on about the same thing since I was knee-high. I grew up in militancy and protests and all sorts of things. That language is all part of who I am. But the real change that I've seen is in the recovery community, where people come in after 40 years of intravenous drug use, and just as a result of psychosocial support, and obviously then them being able to re-engage with services, which is a vital component. You see them getting well, and more, I think my energy is actually better served doing this less visible, less glamorous, less idealistic form of social engagement and community participation, which is not a sexy story that you can tell about revolutionising this and doing all that. But anybody who really works in the community and really makes a difference, no one knows who they are. They're very anonymous most of the time, and they have to put their head above some parapet now and again to make a point. But a lot of the best work that gets done anonymously. It gets done, with no thought about what the big picture is. It's just making little differences, and I think it's an okay way to use your time.
Here.
Yeah. And this is less of a question, more of a comment. Somebody said we need cross-party agreement on so many of these issues. They shouldn't be political. I'm not expecting you to have the answer to this, but how do you get cross-party agreement on something which should be easy but clearly isn't?
We could ask Denmark.
I
think that it's a really important question, but I think it's a really difficult thing to do well. But I'm interested in where countries have been able to do it, how they've been able to get there. How are you able to find your areas of common ground in the kind of greater good interest to feel courageous enough to be able to commit to long-term change? As you'd said, earlier on, I don't know if we've got the answers to that because we're not politicians, and I know it's difficult to get consensus around stuff.
But there's some great examples.
But there are some great examples.
Yeah, Danny Dorling's book on Finland, and for those that know me, I look a lot at Finland, and he wrote a book on Fintopia. And there is an interest. I mean, they have a very interesting way of looking at the public good.
Mm-hmm.
Now, I'm sure that's changing as populism invades all of us, and I think the political landscape will completely change. But they often put things in place just because it's a good thing to do. And they don't, as Obama, used to say that when someone comes up with a good idea about how to sort the country, you get the interest groups and the partisans who kick it around like a football until you lose the solution in the process. Oh, we shouldn't be, we can't be doing that because we are failing people frequently.
Yeah.
And, I don't know what the solution is. I'm trying to hold on to the fact that I think that there are so many issues, and particularly in health, justice is much more difficult. I mean, anybody listening here who's in justice knows that it is completely weaponised, regardless of the evidence. People say, I can tell them the evidence all day, and they'll just say, I know what you think, but I just want more prisons. Now, and that's, I'm going to have to keep on trying to retell people and trying to think about different ways of trying to convince them, as David Gaucus, when he was talking about it this morning. But health, in a way, we should be able to agree about health because everybody deserves, the best of health services, regardless of, politics or race or religion or social class. We all deserve health. And in a way, it's the most important thing. You'd have thought we could agree about that.
Yeah, and I think there probably is more common ground than we think there is. I mean, there is a cross-party group on health inequalities. So I'm interested in what the roles of those types of groups could be in kind of facilitating or enabling conversations that allow us to do things in a more long-term joined-up way. Because I think that it is really difficult when reform or change sits within cycles, and for people to feel confident that it's actually going to change.
Yeah. The other thing with consensus is that it really, part of political consensus will arise when there is public demand for it. So as long as there's political division, which is the definitive characteristic of discourse right now, then even politicians who largely agree on the evidence and who largely think that society could be heading in a certain direction, they just don't feel that they have the public support to take a position which is going to cost them politically. And it's really difficult because we have so many other factors shaping discourse now. We don't just have, the government doesn't have monopoly on health messaging. There's lots of other counter narratives and parallel realities out there. And in a way, as critical as I often have to be of politicians, this is the most difficult time to be a political leader at any level in the history of democracy. because no matter what you do, no matter what you say, there is already someone out there who's trying to characterise it as the opposite of what it is you intend to do, or what the opposite of what you've said, for reasons, you know, that are not always the most earnest. So it's really tough.
Agreed.
We've got a question from Laura, and she has asked, does anyone have any thoughts or ideas on what can be done to address the issue of people not wanting to access healthcare for fear of taking someone else's appointment or space, or being a burden on an already overwhelmed system, which is something that we hear and read every single day. She suspects that this group of people are people who are impacted by inequality more generally.
Yeah, there's been a lot of work done around something called candidacy theory, whether people feel that they are candidates for healthcare, and a lot of that is just it's a belief about whether or not you feel that healthcare is for you, that you deserve it, that it's designed with you in mind, all of these things. And I think it's been shown through the missingness work, it's a big contributor to why people maybe feel unable to take up offers of healthcare even when they are there. And I think, you know, as people feel more remote from healthcare services, so if they're more, you know, remotely delivered on the telephone, or, you know, through really complex navigation systems on Near Me, and there isn't the ability to unpick that in a conversation with somebody that knows you, I suspect that is probably going to become a greater problem, in that the people who do feel healthcare is for me, and I have an expectation around that, are going to be the people who are more easily able to access healthcare, and the people that don't will even feel even less able than they currently do. So I think the inverse care law is interesting. Just going back to that, we know, as you said, Darren, that healthcare is often least accessible for the people who have the highest needs. The second part of the inverse care law says that when there are market forces in play, that is even more acutely felt. Now, so obviously we haven't even really talked about market forces in healthcare, but we've got implicit two-tier systems of healthcare, even within our NHS. So people are not equally able to make use of healthcare as it stands, because our systems are designed by healthy people for use by healthy people. You know, they're designed for people who are able to easily take a day off work and drive to an appointment and be able to articulate what it is they're worried about and have English as a first language, and all of these things that assume that everyone is equally able to do that, when of course we're not. So I don't think there's an easy answer to that, other than being really aware of it when we're designing and delivering services, and always thinking about who is missing and what we're doing for them.
Again, this is a bit of a comment I think might be interesting for you to talk about. We were supposed to see transformation after COVID, but now the crisis is past, and we just go back to what was. Does it feel like that's what's happened in your respective areas?
I mean, yes, but I wouldn't. I wouldn't. I thought for a brief moment during COVID that was potentially going to be a sort of beverage moment, and you saw signs of some political leaders trying to articulate what that might look like, but that just got totally obliterated by sections of culture and media that just cannot countenance anything other than the way things are. My own opinion is that most societies, I mean, I'm sure historians out there might think I'm wrong for saying, very rarely the movements of people drive the real political change that happens in a society. I think most societies are brought to a place of radical overhaul when they stand on the cliff edge of collapse, when it becomes clear that previously unthinkable options are now practical, which is what we all do in a crisis, isn't it? It's like you would never jump out your window, but if your house is in fire, out you go. And unfortunately, it's not idealistic, and it doesn't sound like that's the sort of thing that an activist or a campaigner should say, but when you just look at the cold, hard reality of it, this society is just one of those, it's like one of those people on a stretcher in a hospital corridor that's just waiting for something to happen. and we don't have any say on the direction of travel and the global situation. So we're kind of just a sort of passenger in our own national story right now. So I know that that's not necessarily the most optimistic assessment that you'll hear, but increasingly it seems that that's the pattern that a lot of societies go in, whether we're looking at this in a UK context or whether we're looking at this in a Western context, or a lot of the Western norms now that we take for granted, they're all on the table now. As, oh, are we really a free society? Is this really a democracy? Do we really believe in peaceful transition of power? Do we really believe in this? And everything's up for debate. That's evidence that we're approaching a moment, might not be in our lifetime. It's very slow in historical terms, but we might be approaching a moment, a cliff edge moment, where we really need to either stand up and be counted or make way for whatever comes next. Anyway, have a lovely day, everyone.
So I've been thinking about the transformation that happened during COVID in healthcare. And I remember being asked to talk about, this is when I was doing a different role, silver linings of COVID, of which there were very few. But the things that felt interesting and curious and potentially positive were a transient flattening of hierarchy, where frontline workers across all sections of society were valued for the roles that they did to keep the world going. I'm not just talking about healthcare workers, of course. I'm talking about anybody who was doing a role that kept the world going. That felt really powerful. I think some of the digital innovation that happened was a good thing. I think we need to be cautious about it because there's still a digital divide, and I still think that we should never underestimate the importance of relationships within healthcare. But I think that the ability to be able to have three-way conversations and consultations, the ability to offer choice around whether somebody wants to travel if they work or live in a rural area, the ability to meet quickly with your team, all of those things are in general a good thing, with caveats around them. And I think that we were reminded again of the fact that nobody operates in a silo. You can't operate in a silo. We like to operate in a silo, or we don't. We often do. We don't like it. But when we become more outward facing and we start to communicate more effectively with each other, that great things can happen. It was kind of reminded of that, because it was almost like, well, all our cards are on the table and we just need to work together to find solutions. So that to me felt like the kind of areas where there was real positivity. I think also the massive spotlight that was shown around health and social inequality was not a bad thing. I mean, it's not resulted in the change that we would have wanted to see, but I think suddenly there was a renewed interest in, well, why is it that death rates are so much higher in more deprived areas? Why is it that vaccine uptake is so much lower? Why is it that there were all sorts of things that were COVID specific that kind of just told us what we knew already, but it presented it within a COVID framework. So people were maybe kind of had a renewed interest or curiosity in it. And I think some of that.
That's what I was meaning when that all came to pass. Yeah. That's when it made it politically safer for some people to say, well, look, we know class inequality is a real thing. It's not just a question of hard work and merit and all of that. But over time, that conversation seemed to have been tempered again by that kind of orthodoxy of not wanting to frighten the horses. But I do agree that there were some moments where there was a real understanding of the backbone of our society, the backbone of our healthcare system, all the people who went over and above, put themselves at massive risk, and a lot of cost to families of living in a house with a doctor or a nurse. You know what I mean? Like they're just always gone. Do you know what I mean? Always away, not hugely available. So there's a massive sacrifice, and I think a lot of that was, you're right, brought into kind of sharper focus. Yeah, for sure.
Any other questions?
Oh, yes. There is perhaps from Barry or Mary, there is perhaps no singularly effective approach that could tackle the institutional bias and stigma that affects marginalised groups accessing services in health and justice. But if you had to prioritise one approach, what would it be that would tackle the institutional bias and stigma that affects marginalised groups accessing services in health and justice?
hate these questions.
I mean, that's a really difficult question because it does come down to relationships.
Yeah.
There is no better thing. I mean, I would always say what I hate about COVID is the fact it's gone online. I really miss people. I think human beings are born connected, and the ability to have a relationship, to be able to look you in the eye, to be able to pick up that non-verbal cue, to be able to trust you in person is what we're missing. And a skilled, empathetic practitioner, regardless of where it is, in justice or in health. And it's my favourite phrase, is as close as it gets to being magic without being magic. And I think we lose that at our peril. I think the move to online, I'm sorry, and maybe it just puts me as a Luddite, feels a bit like the death of humanity, which is really, considering we're actually online just now. But it's just, just being in person. I think we just forget about each other's humanity.
Yeah, the digital advances, whether we're talking about big tech, big data, artificial intelligence, these should be used to supplement what we already have. And you would hope that is how they're implemented, but in this kind of era of resource scarcity and a microscope being put on every single resource that is being spent, you can see how this would be used to take shortcuts and make through roads that would undermine that continuity of care, the human contact element. Obviously, as a GP, if you've got a program that can perform a kind of diagnostic for you when you feed in certain information, it's not making the decision. You still have to make the decision, but it's empowering you and enabling you to make the decision no matter how tired you are. It doesn't need a holiday. It doesn't need a break. It can just continue to work. And in an ideal situation, actually, fun enough, is this kind of perhaps a weird reference point. If you look into a lot of the work that the Tony Blair Institute has done, now I don't agree with the direction of travel the Tony Blair Institute wants to take healthcare, which is definitely in the direction of an insurance-based model or creating the framework for that. But a lot of the analysis of how technology could be implemented into health, where we move to a more preemptive model of healthcare through technology, and a lot of the ways that it can be used to solve all these problems about computers not talking to each other and all of that, as an interesting analysis. It's just I don't agree with where it might lead coming from that particular think tank. So the tools are there, they're going to be used, but the human quality, whatever that's taken out, people will suffer, because it's the human being that has to decide. You can't have an AI saying you're getting your benefit and you're not. You're getting an appointment and you're not. Do you know what I mean? Like even a really good AI couldn't be trusted with that.
I think if I had a silver bullet, it would be that. It would be a relationship supplemented by really good, high quality, reliable technology. If I was thinking about what are the layers that we can tackle to address institutional bias, some of it would be how do we make sure that our workforces are skilled, trained, supported and diverse, because I think a diverse workforce is a really important thing, but not always good at that. How do we design and deliver our services to think about who's missing within them? How do we routinely analyse the data to make sure that we're understanding how it's impacting on different groups? Because I don't think we always do that either. But actually, crucially, how do we allocate resource so that it's fair, so that people can work in the ways that they need to work? So there's lots of different layers to tackle it that I think start to get in and about what drives institutional bias, but there's no one easy answer. But if there was, it would be relationships.
Connected to that what came up in that answer there's a question from Alexander who says there's concerns about the negative health impacts of social media and the risks associated with AI and perpetuating biases and misinformation. But could you envisage social media and AI being utilised as forces for good in supporting good health, the healthcare system and access to healthcare? And if I can add on to that, justice as well.
I'll do the health bit.
Yeah, I'll do the health bit quickly, because I think it already is usefully used. So social media is a more modern way of connecting with a vast kind of percentage of the population, I think old-fashioned ways of communicating, having posters in waiting rooms or things on the side of buses or written information is doesn't reach a lot of people. So we need to move with the times and make sure that we're getting to people in the places that they are, whether that's on TikTok or Instagram or wherever it is. We need to be doing that in a way that is sensible and proportionate. And AI is used already within healthcare, in terms of being able to help to make use of science and data. I think the difficulty comes in making sure that the information that people are accessing is true and isn't driving false narrative, misinformation, disinformation, and putting people in harm's way. And that is becoming harder and harder to do because there's so much of it out there. And there's a lot of global work going on around how do we support workforces in health to counter false information or false narrative or disbelief or misbelief when it's playing out in the consulting room. And it's not easy to do because often it comes down to trust. So if you don't really trust someone and you don't really trust the healthcare system, and someone is saying to you, well, there's not really any evidence that the COVID vaccine controls your mind, or whatever the belief happens to be, that can just be perceived as a play out of a power dynamic that is already problematic. So there's something that needs to be done, I think, to support workforces to recognise it and be able to gently, supportively, reliably counter it in a way that doesn't damage relationships, whilst also thinking about what are the bigger system impacts that need to happen to try and reduce that. But that's really big. I mean, that's global and not something that we can really take on as a country even. I mean, it's global.
Yeah, in terms of justice, I spoke to 350 for 4th, 5th and 6th years. And I asked them where they got their information around justice. TikTok, almost exclusively, and Netflix. So, I mean, that's how they get their information. And we're not on that. I mean, I don't do TikTok. I mean, I'm thinking about it, but I get the feeling I'm a late adopter. But it's really interesting about how young people consume and learn about things like justice systems and, what works and what doesn't work and how they should be, sort of the information that they get on that's not, it's not the bizarre conspiracy theories and that you should just jail everybody forever. But in terms of AI, it's a really interesting one. The Americans have obviously been very much ahead of this. There is real challenge with bias in some of the systems, and particularly in justice, where there are, we know that there are racial disparities, particularly in the American context. But I still think there is some real use to it. We do lots of very laborious processes within justice, and I think that as AI and machine learning advances, that we will see it more often in the justice system to try and short circuit some of the decision making. But there will always be a human element at the back of it, a bit like a GP. Is I don't want to be working out if I'm going to go to prison or not by an algorithm. That's been developed in Silicon Valley, but it is coming, and we need to be looking at how we can use it to the advantage of the people in the system, and that's for everybody.
We've had a comment from Gillian, who says she's a volunteer for a prison fellowship and that men are now attending parole boards online, and the solicitor is often online. And those men, especially those who are in their 50s and 60s, get quite stressed because they don't know what to say and they can't consult their solicitor there and then in the same way they would. So there does seem to be some barriers. There's a generational barrier when things are moving to online.
I think there's a bigger barrier than that. We know that people with neurodiversity really struggle in that online world. Some people really like it. So for, when you were saying about choice, some people really enjoy that. It gives them less stress. We know that some of the work in virtual justice, victims, witnesses, may feel safer and more able to give, their evidence or whatever else in that online world. But for others, you just need to be able to see them. They need to be in that space. I've seen people online, and I had someone comment to me, it's very easy to imprison someone who's in a two-dimensional space than it is to jail a crying person who's in the dock, where you can, you just experience what they're going through and be able to connect with them. And for me, that's a core part of problem solving justice.
We've got another quick big question.
Oh, that's for Darren.
From Heidi.
You need more cake.
Heidi has said she wonders if the group could share their thoughts on how inequities in the UK may be impacted by what's happening in the US, with federally funded diversity and inequality work being almost entirely stopped and defunded. How can the UK step in to fill the gap?
I don't know if the UK's having a hard enough time meeting its own needs, what that does, and there is an argument for taking a fine-tooth comb through all government programmes and eliminating spending that's not necessarily efficient and all of that. I'm not saying that you can't perform an audit on government spending, but I think what that discussion does is empower more reactionary forces who see any form of equality or diversity as a sort of synonym for wokeness, which is a stupid way to look at things, especially when it's coming from certain people who have benefited from similar things in the past, whether it's men from working class backgrounds, women from working class backgrounds. A lot of us have been manoeuvred into the positions that we are in life, partly because action was taken to clear a path for us, to demonstrate our opportunities, to take advantage of opportunities, to demonstrate our talents and skills, which in a previous version of society they didn't take account for diversity and inclusion. We would never have been given the opportunity to do it. So I would have just been a manual labourer, I wouldn't have been allowed to express myself with words and be a writer if it wasn't for the fact that it was recognised that, this is a path that I can go on. That doesn't just happen by magic. It's not just sheer force of will. The pieces have to be moved around in order to make that possible. So a lot of the people that are, and I know this is kind of separate to that, but it's worth saying, since it's a live issue, a lot of the people who are most angry about these programmes, it's like they're sitting on a branch of a tree with a saw, cutting themselves down. They don't realise how they've benefited from it. Because if it wasn't for intervention and unequal systems, the only people who would be in charge, the only people who would have well-paid jobs, the only people who would have a say in culture are the people who are born into money, because that's the way that it always works. How we pick up the mess left in the United States, I don't know. I don't understand I don't really understand what we should be doing, because we've got our own battle around all this stuff now. And yeah, of course, there's always going to be piss takers, and there's always going to be money thrown at things that other people don't see the point in, and there's always going to be largesse, and there's always going to be, people who see it as a game and they get in about it and they wear a veil of marginalisation as an organisation so that they can get access to funds and a seat at the table. And of course, every system's open to abuse, but the general principle that we should be helping people who are disadvantaged as a result of characteristics they had because they were born. Come on, man. Do you know what I mean? Come on. Anyway, sorry, I'm getting on my high horse there. This is not really what this is about. But there you go.
Yeah, no, yeah, absolutely. I think that we can probably, the best that we can hope for at the moment is that we can get our own house in order to the best of our ability, and that by role modelling good behaviour and showing the benefits of it, not just because it's the right thing to do, but because it's the fair thing to do, it's the cost effective. It's very expensive to design and deliver services that don't work for everyone because there are costs. So there are different, I think, ways of being able to persuade why this is not only the right thing to do, but it's also really the only way to do it. But I think all we can do is get our own house in order and role model what that looks like.
Next question. So a question from Sarah. What are your thoughts on the connections and overlaps between victims of child abuse or neglect laterally presenting in the justice system having caused harm to others?
I'll take that, and you can jump in. Are you going to take that?
No, on you go. You go.
I thought it was a bit quiet, and I was sort of trying to bail everything out. You sure you don't want to take it?
No, on you go.
Felt like I've done that thing men do, and it's going to get held against me.
No, sorry, I'm not going.
Right, okay, cool. No worries. it's that is a kind of delicate conversation. One, the idea that people have trauma, this then predisposes them to harming people later, like the abuse, the victim can become an abuser. That's a sort of myth, which is just one thing to sort of clear up. But generally, when we're recognising the role that early years maltreatment or neglect can play in determining outcomes further along the line, we don't need any more evidence. We really don't need any more evidence. Even if you don't agree with the ACEs study, there are so many other parallel studies out there that show how that stuff shows up. But saying that, sometimes I think those of us in the trauma space, in the trauma-informed space, because we spend a lot of time around people who've suffered, we forget about the impacts that our wounds can have on other people, and the role of self-awareness and accountability and taking responsibility, even when it doesn't seem fair, but just because it's practical. And I would like to, and I'm hoping with my book, to create space for a conversation around that, because as well as it being more nuanced than often the discussion in the trauma space accounts for, there are real practical political reasons to open the discussion up, to acknowledge that you can suffer as a kid, that can show up in your behaviour later, and you can end up getting ingested and ricocheted around systems, and that has to be acknowledged. But in amongst all of that, there's often victims as well. You know, there's victims of I've perpetrated harms in my life as a result of not having the tools to cope emotionally, psychologically, and for some reason, and I talk this discussion about trauma a lot of the time at the big conferences and all of that, it's a taboo thing to say to someone, you know, because we lean so heavily on the victim side of the story. But everybody's a victim and a perpetrator of something. And any discussion around that sort of stuff, I think, needs to acknowledge that most people who are in prison, they've done something that warrants them being there. And that just because the circumstances that led to that were out of their control, it doesn't mean there's not a kind of locus of accountability somewhere within them. And I think that's a much more practical, sensible way to ground any of these discussions, personally.
I think it's, you know, just having worked in this area for such a long time and knowing people who have had such terrible things happen against them, the acknowledgement and telling people that they've been sexually abused as a child is always the very last thing to come out. I've known people for 10, 20 years, and it's only just often recently that they've said, oh, and by the way, this happened to me when I was a child. The fact that we're able to have that conversation now, due in part to some of the work that's been going on in Scotland around, you know, trauma and adverse childhood experiences, is allowing people to speak about it. The child abuse inquiry, you know, it's come to the forefront that there are people in prison who have had terrible things happen to them, who may then have, you know, started to drink alcohol or taken drugs to quiet down those terrible things, or to just dull the pain that they've had, that they end up in prison. They're not different things, but there is no unique correlation as well. I know people who have never been in contact with the justice system, whose life story would keep me awake at night. But I think we should stand in awe in many experiences about when people tell us what's happened to people, and try and be an active listener. Because if they're telling you it, and if they're telling it in a GP surgery, you know, when you talked about, I heard someone talk about the cause of the cause of the cause. And we talk about Northern Ireland and a whole range of other things, but I think it's quite interesting when people come in with, I don't know, non-specific pelvic pain, and then you have the time to be able to speak to them, to listen to them, and actually the cause of the cause of the cause can be something way back to child sexual abuse that's happened. And I actually think that that's a good conversation to be having in Scotland, because the shame that people have carried, and it's not their shame to have. I don't know. I think it's still. I mean, I'm still affected by some, you know, some of the things that people have told me, but it's a complicated subject.
It's important people do come from that perspective where they are immersed in that side of it, because I don't work in that field exclusively in terms of I'm always bouncing about. So you experience different attitudes towards these things. And for me, that sort of, I guess that kind of moderates the way that I talk about trauma and victimhood and perpetrators. But you do need some people who are seeing it almost solely from that perspective, particularly your background in policing. You've seen it from the other side as well, you know?
Yeah.
And you obviously as a GP, people need to feel you're in their corners. Maybe not your role to say, "Hi, but you're a bit of a dick." Do you know what I mean? Do you know what I mean? Sorry for the language. You know, but that I guess that's maybe a different discussion for a different time. But definitely kind of recognising the complexities.
And just to finish up, and this is for all of you, if you all don't mind answering it. We've touched on quite a lot of quite dark stuff, and it feels a bit like dark days sometimes at the moment. But do you have hope for the future or for change, or and if you do, what does that look like to you?
Oh yeah, absolutely. Somebody sent me a picture last night of actually someone who I knew a long time ago. I'm going to say his name. His name is Eddie Gorman, who I worked with decades ago. And he's like the Pied Piper now. He runs this massive recovery community down there. And I absolutely love him. You know, he just makes me smile with some of the stuff that's done. And I know loads of people around Scotland who just do small bits, but they make massive difference to people's lives. You know, whether it's G20 in Glasgow and the work they're doing, you know, supporting young people and letting them, you know, achieve their potential, whether it's medics, you know, and I work with Medics Against Violence, some of the work that they've done. I see so many great things. And I think, switch off your social media. Don't be listening to it. I mean, it's like barking into cyberspace. But actually try and engage it and say to people, tell me something good that's happened. Instead of that old Scottish Calvinist thing, oh, you know, it's terrible, you know, it's terrible and the weather's awful. Tell me something good that's happened. Everybody has something good. You would have some, and so would you. And, you know, just go and surround yourself with some of the positive architects that are out there.
Yes. So I think it is really important to think about, where am I finding the joy at the moment? And more of that is going to get my attention and energy. But I think something I do feel genuinely hopeful about is the renewed interest in how do we create the conditions for relational continuity of care. So there's been lots of conversations happening over the last couple of years. There's been lots of papers published. There's been lots of interest within the training community, within the within kind of policy making, within discussions that I've had about just about all the things that we talked about in terms of it's better for patients, it's better for people working in the system, and it's better for the NHS in terms of sustainability. I think it feels like there is a momentum around it that we want to get to a place where we see a successful healthcare system as one that nourishes healthy relationships, whether it's healthy relationships within it, so that people they feel able to communicate with each other well and share information and work together as teams, and whether it's relationships between the caregivers and the care receivers. But I genuinely think there is an interest in thinking more broadly about how we define and measure success within healthcare. So that is what gives me joy at the moment, is this sort of renewed interest in relational continuity of care, because I think it is the silver bullet. And I think it would give so many opportunities for improvement, but just joy, more joy in work, more joy for people's encounters with healthcare. So that for me is what I'm holding on to for now.
And we have so many good stories. We have no under 18s in prison. I mean, that is, I mean, when I started, 20 odd years ago, I'm not going to say anymore, we had hundreds and hundreds and hundreds of under 18s, but zero under 18s in prison. So you need to hold on to some of the good stories that are out there.
I think that's kind of good last word. And I've contributed enough negativity, so I'll just leave it there. But I thought that was great, a great point there, just kind of ending it by focusing on the specifics,
So we come to the end of Community Justice Scotland's national event for 24-25. So just to hand over to you, Karyn, just to close.
Just to say thank you very much indeed to both our contributors. Dr Carey Lunan and Darren McGarvey. And thank you to you for listening. And, you know, even though I'd like to see you in person to be able to see your engagement. This is a second best, but thanks so much for attending.